Each year, thousands of people suffering from heart failure look for a way to gain more time. Heart disease threatens to shorten their lives in spite of optimal medical therapy available. For those with severe heart failure, the only hope for time is a heart transplant or some device that can take over the pumping action of their failing heart. The HeartMate 2 left ventricular assist device, or LVAD, was developed to take over the pumping function of the weak and failing heart. This device can help two types of patients. One, those who need temporary support while waiting for a donor heart, often called bridge to transplant patients. And two, patients who are not eligible for a heart transplant, but who can benefit from long-term support of a heart pump, often called destination therapy. As can be inferred, patients who have LVADs for destination therapy will have it for the rest of their lives. The heart is a round, fist-sized muscle located in the thoracic cavity. It's divided into 4 chambers. The upper chambers are the atria and the lower are the ventricles. Each atria and ventricle are further identified as being on the left or right side. Blood enters the heart into the atria. The right atria collects blood from the systemic circulation and the left from the pulmonary system. Blood initially flows passively through the atria to the ventricles through the valves between them until the atria contracts, pushing the remainder through as the valve shuts. Then the ventricles contract, ejecting blood out of the heart. Blood from the right ventricle enters the pulmonary artery and heads to the pulmonary system. Blood from the left ventricle enters the aorta and can be transported all throughout the body. Since the ventricles eject blood into the body, they are larger than the atria. And since the systemic circulation is larger than the pulmonary, the left ventricle is larger and more muscular than the right. As the left ventricle accepts blood from the lungs and then provides it to the rest of the body, any dysfunction of it can cause potentially serious complications. Failure of the left ventricle can lead to issues such as fluid backup in the lungs from congestive heart failure. It can also decrease cardiac output as the muscle of the ventricle cannot pump with the strength necessary for optimal perfusion. This can lead to decreased oxygenation throughout the body, as well as chronic hypoxia and ischemia to vital organs. Heart failure has many potential causes. For some, it occurs after many years of untreated hypertension. For others, it may be secondary to tissue death from a myocardial infarction. Failure can even be related to a congenital disease process. Therefore, heart failure doesn't just affect the elderly. Patients may be in their teens or even middle age. It's important to realize there is no such thing as a classic patient with an LVAD. They may be young, they may be old, they may be thin, they may be overweight, but they all share the problem of a failing heart. While there have been and are other LVADs in existence, the one you might come in contact with is the HeartMate 2. There is at least one patient living in the Long Beach area with an LVAD and 18 in this part of the country from Santa Barbara to Las Vegas. As our city and region do attract tourists, there is an increased chance of an encounter with other outside patients. The pump is connected to tubing on one side to the apex of the heart in the left ventricle. The opposite side of the pump is connected to tubing that connects to the aorta just above the aortic valve. The pump will assist with the moving of blood through the body. A small electric motor inside the LVAD drives the pump. The LVAD has only one moving part, a small spinning rotor that receives power from the system controller. Veins on the spinning rotor move blood through the pump, which is capable of providing flow between 3 to 10 liters per minute. It's important to note that the HeartMate 2 is not an artificial heart, nor is it a heart replacement. The patient's native heart is not removed. When attached, the HeartMate 2 is designed to assist or take over the pumping function of the left ventricle. The remaining chambers still function on their own. The HeartMate 2 is designed to restore blood flow throughout the body, enabling the patient to breathe more easily and feel less fatigued. The patient's organs will receive more blood than they did prior to receiving the LVAD, and this will most likely improve their function. After receiving an LVAD, patients generally feel more energetic and are able to resume normal activities that they were unable to do prior to implantation. The pump has a driveline, also known as a percutaneous lead, that extends from the electric motor and exits the body to connect to a small computer called a system controller. This device makes sure the pump is working correctly and uses lights and sounds to let the patient know how the system is working and of any complications. The system controller, and therefore the pump, can receive its power from one of 3 sources. When patients are up and moving or out in public, it is controlled by external batteries attached to clips. A set of these two batteries will usually provide from 6 to 10 hours of power. Patients normally carry multiple batteries when away from home. Patients may also receive power from a power module, which is connected to an AC outlet. When connected to the power module, they are considered tethered and have limited mobility. On the other hand, the power supply is unlimited, as long as there is not a power outage. Because of this, patients generally sleep attached to the power module. Patients will also have an emergency power pack. This large battery is a one-time use energy source that can provide up to 12 hours of power in situations like a power outage. When the patient is connected to the power module, information from the system controller can be seen on a display module. This display shows how the pump is working by displaying information such as pump speed, flow rate, power, and other information that may be useful for the patient, as well as the LVAD coordinator at the patient's hospital. At the patient's home, you will also find battery chargers that the patient uses to power up the 14-volt lithium-ion batteries that he or she will use when mobile. Additional accessories your patient may have include holsters for carrying the batteries, a case for carrying the system components, and a travel case for carrying emergency or backup equipment. Realize that depending on how a patient chooses to dress themselves in public, it may not be immediately obvious that a patient has an LVAD. When looking at all the components, you can see how they're interrelated. The pump, which is attached to the heart and aorta, is located within the body. It's connected to the system controller by a percutaneous lead that exits the body from a surgical site in the abdomen. The system controller, which controls the pump's action, is located outside the body and is connected to the pump's power source, which may be in the form of batteries or the power module. All of these components work together to assist the failing heart to improve patients' cardiac output. The assessment and care of a patient with an LVAD can seem intimidating. Even though the patient has a sophisticated piece of medical hardware in his or her body, many aspects of our assessment remain the same. On the other hand, there are points that have to be altered specifically for the LVAD patient. One of the most important aspects of care of the LVAD patient is to be aware of the percutaneous lead exiting the body that connects to the system controller. This wire provides the power necessary to run the LVAD, as well as the information as to how fast the pump is to rotate. We need to be extremely careful when cutting patients' clothes so as not to sever the wires. We need to also be aware of the system controller. As it is attached to the percutaneous lead, rough handling of it can potentially damage wires or the pump. Dropping the controller could also be an issue. Be aware of the controller and wire locations when moving a patient on a gurney. It goes without saying that severing these wires could be disastrous and could lead to a shutdown of the pump without any way for you to restart it. It is also important to note that the patient must be connected to a power source at all times, whether it's the power module, batteries, or the emergency power pack. If necessary, the patient or their caregiver may transfer the system controller from one power source to the other. The pump is designed to be able to function normally with only one power cord attached to a source. This engineering design allows for the switching of power sources by disconnecting from the old source and then connecting to the new source one cord at a time. The patient should never have both power cords disconnected or both batteries removed from the clips, as this will stop pump flow immediately. The primary assessment will begin like most, in that you will assess the environment and form a general impression. This may result in your identification of some of the equipment in the patient's house or possibly identifying the system controller and batteries on the patient. Your assessment of airway and breathing is not different for the LVAD patient compared to any other patient. If they appear to need oxygen or ventilatory support, it should be initiated. Your assessment of circulation, though, will be different and even quite baffling. Because the LVAD moves blood in a flowing manner as opposed to pulsing, the patient's pulse will be significantly dampened to the point to where you may not even be able to detect it. You will also most likely not be able to get a blood pressure with a stethoscope or automatic cuff. Listening to the heart sounds will not even give you the classic lub-dub sound. You can begin your assessment of the patient's circulation by looking at the system controller. Now, while you're not required to interpret all of the lights and alarms, you can know a few. If the pump is receiving power, you will see a green circular light illuminated solidly. If you see a red broken heart illuminated, which would be accompanied by a steady audio tone, the patient is in a life-threatening situation. A red heart alarm goes off when the pump flow is dangerously slow or is stopped. The system controller, and therefore the power supply, has become disconnected from the pump, or if the pump is not working properly. Seeing the battery symbols light up means the system power is running out. A yellow battery indicates 15 minutes of power is left, while a red battery means only 5. After inspecting the system controller, listen over the left side of the abdomen with the stethoscope for a humming sound. If the pump is functioning, you should be able to hear this sound in both the left upper and left lower quadrants. Also, check with the patient to see if they have a Doppler stethoscope, as this will be the only way for you to assess their blood pressure. When using a Doppler stethoscope, you will only be able to obtain a systolic blood pressure. Prior to cuff inflation, listen to the brachial artery in order to hear a whoosh. Then pump up the cuff until the sound goes away. You should only need to go as high as 120 millimeters of mercury. As the cuff deflates, the first sound you hear will be the patient's blood pressure. Patients with LVADs have typically low blood pressures, and you should suspect to obtain a reading between 60 and 90 millimeters of mercury systolic. Believe it or not, any blood pressure above 90 systolic will be considered hypertensive for them. Also, you will not consider the LVAD patient hypotensive until their blood pressure drops below 60. Your circulation assessment often finishes with observations you would normally make, including capillary refill time, skin signs, and looking for significant external bleeding. The primary assessment then can round off with a neurologic assessment, which includes a Glasgow Coma Scale, along with sensation and motor function in all 4 extremities. The neuro exam is very important, as the patients with an LVAD have an increased risk of clot formation. Typically, they take medications such as Coumadin and aspirin to prevent this, but the risk of stroke, whether from a clot or a bleed, remains significant. While a person with an LVAD can contact 911 for any reason, we will review the 6 most common ones. They are, in order of frequency, GI bleed, cardiac arrhythmia, stroke, right-sided heart failure, equipment failure, and sepsis. Prior to implant of an LVAD, the patient's body operated with low cardiac output due to the chronic heart failure. Over time, the patient's blood vessels may have deteriorated and become weakened, or even formed, in some locations, arteriovenous malformations. An AV malformation is an abnormal connection between an artery and a vein. When an LVAD is in place, blood flow and cardiac output improve significantly. This might cause bleeding from some of these damaged vessels. When you consider that the patients are routinely on anticoagulant therapy, it can make matters even worse. You should treat a GI bleed on a patient with an LVAD the same as any other. Oxygen administration, IV access, and consider fluid administration. Remember, as mentioned earlier, the blood pressure parameters are different, as they're not considered hypotensive until their blood pressure is less than 60 millimeters of mercury systolic. A second condition that may cause an LVAD patient to contact us would be a cardiac arrhythmia. Most patients who have an LVAD implanted also have an AICD as well. AICD stands for Automated Internal Cardioverter Defibrillator. In essence, this is a small AED implanted in their chest. If the patient's heart enters an arrhythmia, the device may fire, and LVAD patients are instructed to contact 911 anytime their device fires. One possible cause of the arrhythmia could be hypovolemia and/or dehydration. The decrease in circulating fluid does not alter the flow the LVAD is trying to achieve. In these situations, the sucking forces of the LVAD may pull on the septum of the heart and cause an arrhythmia. If a patient is noted to have an arrhythmia, paramedics should treat them by utilizing the same ACLS guidelines they would on non-LVAD patients. All ACLS medications and procedures are able to be administered to an LVAD patient. If the AICD was unsuccessful in terminating the arrhythmia, and the situation calls for paramedics to administer a synchronized cardioversion or defibrillation, it is allowed. It is recommended, though, that the multifunction pads be placed in the anterior-posterior position. LVAD patients may experience a stroke. Because of the possibility of clot formation, the need for anticoagulation, and the improved blood flow post-device implantation, this could either be an embolic or hemorrhagic stroke. Interestingly enough, our care for the LVAD patient with a stroke does not differ from any other stroke patient. We should still perform the MLAPS assessment on them to determine if they should go to a stroke center. We should also administer oxygen, assess blood glucose levels, and initiate IV access. If they are MLAPS positive, they should be brought to the nearest approved stroke center. The only potential difference in the care of the LVAD patient is that they're not eligible for the FAST-MAG study, so we will not consider enrolling them. Please note, There isn't anything on your paperwork that states LVAD patients aren't eligible for the FASTMAG study, as there are so few of them out there. This is information that comes directly from the LVAD coordinators at Cedars-Sinai Medical Center. Since LVAD patients are already experiencing severe heart disease that has affected the left side of their heart, it is possible that they may have a degree of failure on the right side. As you may recall, the right side of the heart receives blood from the body and pumps it out to the lungs. From the lungs, it goes to the left side. In case of significant right-sided failure, the heart cannot pump the normal amount of blood from the body through to the lungs. This can result in the classic signs of pedal edema and jugular venous distension. Because the amount of blood pumped to the lungs is decreased, the amount of blood pumped out of the left side, and in these cases specifically the LVAD, is also decreased. This decrease in cardiac output will present with signs of shock, such as pale, cool, diaphoretic skin, altered mental status, and hypotension. Treatment for right heart failure will include oxygen administration, vascular access, and the potential to administer fluids or even a vasopressor in the form of a dopamine drip. As a pre-hospital provider, you aren't required to know the equipment associated with the LVAD patient intimately. In fact, the patient and any of their caregivers will know it much better than you. But your presence may be necessary if any of the components begin to fail. The devices used on these patients are designed with many redundant systems to prevent one issue from leading to immediate catastrophic failure. For example, the system controller has two separate computers within it, the primary one, which runs the device, an identical second one in place only in the event that the first one fails. Another example is the battery system. While the system controller is designed to be connected at all times with two cables to the power module or to two batteries, the pump runs effectively on just one. This allows for changing batteries or switching from batteries to the power module to occur without any impact in flow or patient condition. Therefore, even when a mechanical problem occurs, it may not result in an immediately life-threatening situation, but rather one that just requires the patient to make plans to get to their hospital to have the situation evaluated. And while you don't need to know the meanings behind all the warning lights and sounds, you should be aware of the red heart alarm. This is indicated by the broken heart symbol illuminating red on the controller along with a steady audio tone. This alarm could indicate that the percutaneous lead coming from a patient's abdomen has become disconnected with the system controller and is therefore not powering the LVAD. It may also indicate that the battery power is extremely low and in danger of running out imminently. Red heart alarms may also indicate that the pump is either stopped and therefore not flowing, or that it's not working properly, causing low flow, or that the patient may be experiencing a condition such as an arrhythmia that is causing very low flow rates. In these situations, check with the patient and/or the caregiver for direction. Prior to your arrival, they should have checked to see that the percutaneous lead was attached correctly to the system controller and that the controller was properly connected to a functional power source, such as the power module, batteries, or emergency power pack. They may also have replaced the system controller with a backup that they keep with them. Find out what they have done and ask them to show you the connections. This step helps to confirm that everything is hooked up and may also help them to double-check any of the adjustments they have made. Also, you should be able to converse with one of the LVAD coordinators from the hospital. Patients and caregivers are trained that in the event of a red heart alarm, they contact 911, but then also contact the patient's hospital immediately to speak to a VAD coordinator. The coordinator may be able to assist in the care of the patient. If you find yourself in a situation where the LVAD coordinator was not contacted, you may contact them yourself. The system controller will have a sticker on it with the contact information of the hospital. The patient should also be wearing a medical alert tag with the number on it as well. When you call the number, make sure to press 0 for the operator, who can then connect you to the LVAD coordinator. If the device is connected to the patient correctly and appears to be receiving power, continue with your assessment of the patient by evaluating their ABCDs as we have previously discussed. The sixth most likely reason you might get a call for a patient with an LVAD could be for sepsis. While everything is done to keep the site where the percutaneous lead exits the abdomen clean, infection can still occur. If the infection becomes serious enough, the patient could eventually experience septic shock. These patients need to begin antibiotic therapy to combat the infection. Two conditions not mentioned yet with regards to treatment so far are chest pain and shortness of breath. If the LVAD patient were to complain of chest pain, we would approach our care just as we would with any other patient. Also, if they meet the criteria, we can transport them to a STEMI receiving center. These patients should receive oxygen and vascular access. We can administer them aspirin, even though they're most likely taking aspirin on a daily basis. But we could run into a small problem with administering nitroglycerin. As you may recall, I mentioned earlier that the typical range of blood pressures for an LVAD patient is between 60 to 90 systolic. But our treatment protocols only allow nitroglycerin to be administered if the blood pressure is above 100. Also, since you don't carry a Doppler stethoscope, you may not be able to obtain a blood pressure on the patient anyway. The coordinators at the LVAD Center have informed us that administration of nitroglycerin for LVAD patients is okay, even with a systolic blood pressure between 60 and 90. They recommend assessing for other signs of good perfusion as well as consulting with the base hospital physician. It is also possible that they may be able to talk with the base hospital physician and offer guidance. In the end, though, it would be that base physician's decision whether or not to allow the administration of nitroglycerin with a blood pressure below normal parameters. Now, in addition to blood pressure, there may be one other obstacle to nitroglycerin administration. Some patients with LVAD suffer from hypertension within their pulmonary system. A medication that they may be prescribed is Adcirca. Adcirca is generically known as tadalafil. Tadalafil, too, is the generic name for Cialis. Therefore, the same medication that some will use to treat erectile dysfunction can also be used to treat pulmonary hypertension under a different name. It is important that you be aware of this, because if you do not recognize the other names for Cialis, you may run the risk of administering nitroglycerin to a patient who shouldn't have it. Also, it's not good enough for you to simply ask the patient if they're taking any sexually enhancing drugs. Even though Adcirca and tadalafil are the same as Cialis, the patient may make no connection between their prescription and the treatment of sexual dysfunction. Making sure that you are aware, possibly by maintaining notes of different names of medications that are contraindicated with nitroglycerin, will help prevent a mistake from happening. If your patient is suffering from respiratory distress, you can utilize all of the treatments that you would consider for any other patient. This may include oxygen, venous access, albuterol, and nitroglycerin under the same restrictions we had earlier mentioned. LVAD patients can also receive CPAP as there are no issues with its use. Again, because the blood pressures that these patients will have under normal circumstances will be low, you should contact the base hospital physician prior to applying CPAP. Even though the numerical reading of their blood pressure is below what we would normally consider for CPAP use, we may be able to utilize this treatment with base hospital consent. One last comment about respiratory distress. As these patients suffer from heart failure, suffering respiratory distress from pulmonary edema is a real possibility. These patients know their body very well and on a daily basis will weigh themselves, record their LVAD flow rates, and maintain contact with the LVAD coordinators. Many times, because of their personal initiative, they will be admitted to the hospital before they begin having respiratory issues. After hearing so much about the LVAD and how the patient presents, one of the questions that's crossed your mind must be, well, what about a cardiac arrest? Cardiac arrest management throws in a few twists to patient care, and the first is how to recognize it. Since the patient most likely does not have a palpable pulse even when fully awake, that assessment will not be helpful. The fact that there is no lub-dub on chest auscultation rules out heart sounds as a method. Therefore, the best method of recognizing cardiac arrest will be multidimensional. Obviously, the patient who is unconscious with a GCS of 3 and no spontaneous breathing or agonal breathing is likely an arrest. Make sure to also look at the patient's skin signs as an indicator of perfusion. Skin that appears significantly pale, ashen, or cyanotic may lead us to believe that the patient is an arrest. Pupil assessment may also be helpful, as the arrest victim may have dilated and fixed or sluggish pupils. Furthermore, paramedics can assess the patient's ECG to evaluate whether or not the patient is experiencing a cardiac arrest rhythm such as asystole or ventricular fibrillation. If you believe your LVAD patient is in cardiac arrest, it is important that you do not perform chest compressions. I'm going to repeat that. LVAD patients who are in cardiac arrest do not receive chest compressions. The primary reason for this is that the act of performing chest compressions will likely rip the connections made from the pump to the heart and aorta, almost ensuring the patient will not survive. Secondly, the LVAD could still be pumping, So it is possible that there may be some, albeit a small amount, of blood flow actually occurring. All other cardiac arrest management techniques are considered acceptable, which includes bag valve mask ventilation, AED and manual defibrillation, IV or IO access, medication administration, and advanced airway placement. BVM ventilation should occur with one breath every 5 to 6 seconds. With regards to defibrillation, it's recommended to apply pads in the anterior-posterior position and follow the normal sequence for energy settings. Also, you should not disconnect the system controller or power supply to the pump. The pump needs to continue functioning. Pharmacologically, medication dosages as well as timing. For example, 1 milligram of epinephrine every 3 to 5 minutes would be the same. All LVAD patients will have a physician's order for life-sustaining treatment, or POLST. This form will clearly indicate that no chest compressions are to be administered to the patient, but that all other aspects of cardiac arrest management are to be adhered to. It is highly likely that these patients will be transported as opposed to being pronounced on scene. So chances are reference 814 criteria of asystole greater than 10 minutes will not apply to them. Also, if you feel you do have a patient that meets other reference 814 criteria, contact the base hospital along with the LVAD coordinators to identify what is the best course of action. Remember, depending on the clinical situation, there still may be blood flow occurring, and the patient may be able to survive this event, but it's just not as clear-cut as it would be for a non-LVAD patient. To round out our discussion of LVAD patients, I wanted to provide some additional information about them in general. As you can guess, they are a special kind of patient. The implantation of an LVAD is a major life-changing event, as every aspect of their life now must take into consideration the fact that they have this device. They need to make sure that they're always attached to a power source for the device to function. They have special procedure and equipment whenever they take a shower. The idea of just running out for an errand also means they need to take and make sure they have their spare equipment with them. For many, they live each day hoping to receive a call that a donor heart has become available for transplant. Others know that the LVAD will be with them until the end. It can be a huge burden. On the other hand, most LVAD patients are able to enjoy a better quality of life than they did prior to implant. Because of the improved cardiac output, they're less likely to get short of breath, able to walk longer distances than before, climb stairs, and actually enjoy their lives. Many realize the LVAD is that second chance their own heart wasn't giving them. In the past, patients with LVADs rarely left the hospital. For many of them, their hospital room became their home. The creation of smaller LVADs like the HeartMate 2 has allowed these patients the freedom to live in their own homes and communities. The goal of Cedars-Sinai LVAD Center is to have patients return home within 21 days of implantation. There's a wide variability in the length of hospital admission times. The shortest amount of time a patient spent after implantation, though, was only 9 days. LVAD patients do not make this journey alone. There is usually one or more caregivers involved in this patient's life. Caregivers may be family members, close friends, or even private nursing personnel. These caregivers, just like the patient, are taught all about the LVAD system. They become just as capable as the patient with knowing how to switch power sources, interpret alarms, when to contact the LVAD coordinators, and how to function in potential emergency situations. Because of this, the caregiver should be viewed as just as important as the patient in your eyes. They, like the patient, will be your best source of information on scene and can help you identify what actions need to be performed. In fact, on a handout from Cedars-Sinai, it states definitively, ensure patient, caregiver, and LVAD equipment are never separated. Most of the time, the patient and their caregiver are never far away from each other, so you shouldn't ever have to worry about performing any actions such as switching power sources or system controllers. Either the patient or the caregiver can handle these functions. But if for some reason the caregiver is not present and the patient is unable, you may need to intervene. Your best course of action will be to contact LVAD coordinators as soon as possible. Remember, the phone number should be on a sticker on the system controller as well as on a medical alert tag the patient is wearing. Upon calling the number, press 0 for the operator and let him or her know you need the LVAD coordinator. The LVAD coordinators can offer advice and assistance over the phone as needed. Along with caregivers and the LVAD coordinator, another source of information for you should be a binder that contains specific information about the patient and the equipment. The patients are supposed to have the binder with them or easily accessible all of the time in case of emergencies. Check with the patient or caregiver if this binder is available. As you've already seen, an LVAD patient requires a lot of equipment, whether inside the home or out in public. Whenever the LVAD patient leaves the house, part of their routine is to ensure they have all the equipment that they need. This typically involves a number of spare batteries, a second system controller, emergency power pack, etc. Should an LVAD patient ever be transported by EMS to a hospital, it is imperative that we bring all of their equipment with us. This includes items we would normally think of leaving at their homes, such as battery chargers, power module, spare cables, etc. The reason for this is that we will not be transporting this patient to their VAD hospital. Rather, we will be taking the patient to the most accessible receiving facility. That facility will coordinate with the patient's hospital for the best course of action and potential interfacility transport. The MAR, though, will not have any of the equipment specific to the patient's LVAD. So if it's not brought to the hospital, the patient will not have access to it there. And in an emergency, that could be detrimental to the patient's well-being. So to reiterate, when you transport an LVAD patient, whether from the home or out in public, you must ensure that every piece of equipment related to the LVAD goes with the patient to the hospital. This may feel burdensome, but remember, the local hospital will not have any of this equipment available for the patient. If we don't bring it, the patient won't have it. On that same train of thought, even though patients are supposed to take equipment with them whenever they leave the home, there may be a time when they forget and an important piece of equipment that they need is actually not on scene. If this is the case, we may need to coordinate a plan to get the patient and their equipment together. While it doesn't seem to make sense to quote-unquote transport someone home, we may need to find a way to get another individual or caregiver who can get access to that equipment and meet us either at the hospital or maybe even en route if it is an absolutely critical piece of equipment. The reality is that we may never be faced with this type of situation, but it is important that we realize that LVAD patients are very different from the average one, and that a certain degree of operational flexibility may be necessary to ensure that we do the right thing for this patient. The LVAD coordinators wanted you to know that it's entirely possible that you may encounter an LVAD patient that did not come from Cedars-Sinai. There is no difference in caring for that patient from what we have previously discussed. Also, it's possible that an LVAD patient may be visiting from out of state. LVAD patients are approved to fly on commercial jets, so we could encounter a tourist. Keep in mind that former Vice President Dick Cheney now lives with an LVAD. While I can't say for sure, I feel pretty confident that he's a very mobile individual, and there are likely other VAD patients equally as mobile. In summary, left ventricular assist devices are an amazing form of technology that has literally breathed life into some who have had it slowly slipping away. Even more intriguing is where this technology has progressed to over time and its ability to allow patients to be at home and enjoy the second chance they've been given. For some, this device keeps the patient alive until a heart transplant is available. For others, it allows them more precious time in life. LVAD patients may be intimidating and the assessment baffling. By recalling the subjects we covered today, you can make sure that we do our part to give this patient the best care possible and help them to continue to enjoy that second chance at life their own body wasn't giving them.